Hello everyone. So now we're going to continue our discussion to summarize all these big case scenarios, these 10-line case scenarios in one line, which is the most important line that you need to recognize when you read it in the question stem, and that give you the answer. Okay, so let's start with the just one question here. Like, let's say you see 37-year-old came in with sore throat, fatigue. These are non-specific. Okay, and then you can have 2 episodes of diarrhea as well, new rash. And then they give you a bunch of tests. What do you test for? Crohn, for HIV, for E. coli. This is clearly the best next step. You want to check for HIV. Okay, this is a systemic new HIV infection could present like that. Okay, another case, you have somebody like 55, came in with fever, flank pain, CVA angle tenderness, vertebral angle tenderness as well. And you gave the patient antibiotic, took antibiotics, but no improvement. Still have leukocytosis and everything after a few days. So, and they tell you, okay, what's the diagnosis? What goes in? So, pyelonephritis resistant to antibiotic. What is that? What could be causing that? You need CT. We know after 2 days, if no improvement, you do CT scan. Why? Because you suspect perinephric abscess, and that's exactly what could be dealing with right now here. Okay, so perinephric abscess could be because if you're diabetic, if you have Staghorn calculi, if there's obstructive malignancy, if there's recent urinary tract infection with bacteremia, there's high risk. And the way you present fever, flank pain, abdominal pain, you can have dysuria or increased urinary frequency, and no improvement in urinary tract infection on 3 to 5 days of therapy, and can be asymptomatic in someone who's elderly or diabetic. So you gotta watch out for that as well. Somebody's not getting better, you can do CT. Alright, now this is a simple question. Tattoo complications, bacteria. What bacteria could like to be in like tattoos? Staph species like tattoos, Others, Mycobacterium, Chelonia, and the Pseudomonas species. They like tattoos as well. This is local infections. There are systemic infections associated with tattoos as well. They like tattoos. Hepatitis B, C also like. If you like tattoos, hepatitis B and C like that too. Acquired hypersensitivity reaction, keloid, you can have that, generalized skin reaction. You can have delayed skin reaction as well to the tattoos. So these are some complications with tattoos. A lot of people like tattoos. There are some other bacteria and microbes like tattoos as well. Okay, now another case is kind of interesting. 32-year-old, multiple sexual partners, sore throat, fatigue, diarrhea, rash. This is like for HIV, right? I think it's HIV. They can also, another clue they give you, tender ulcer on the buccal mucosa, So now they ask you what is the best next step. You do antiretroviral therapy, okay? So you do antiretroviral therapy, combination antiretroviral. Now this brings us to a discussion of HIV. HIV usually come in with fever, sore throat, arthralgia, can have macular rash all over, general GI symptoms. Like you can have diarrhea as well, and usually 2 to 4 weeks after exposure. So let's say you have sex with somebody with HIV, like 2 to 4 weeks, you can develop that. Viral load is markedly elevated, more than 100,000. And HIV antibody testing may be negative yet, could be seroconverted, not yet seroconverted, so it can be negative as in the beginning. And then CD4 may be normal as well, so this wouldn't tell you much. So viral load is a good marker in the beginning, and then you treat with combination antiretroviral therapy and partner notification. Secondary prophylaxis is recommended as well. Okay, now there is this case is kind of interesting. They give you an 18-year-old man came in with painful left elbow lesion. Okay, and then you look at the lesion. There is a fluctuant lesion. Yield 3 ml of purulent material. Okay, purulent material. That's not good, right? Material it's infected. So how do you treat? So they're asking you how do you treat skin abscess. Okay, give Bactrim. Trimethoprim, sulfamethoxazole, because this is skin abscess. So now the question is that when do you treat an abscess? Abscess, you treat it if it's more than 2 centimeters, if there is extensive surrounding cellulitis, if there is signs of infection like fever, chills, tachycardia, leukocytosis, if there is multiple abscesses all over, if there is extremes of age, like very young, very old, you know, lack of response to incision and drainage as well, you can give them Bactrim, and or doxycycline as well could take care of these bacteria, skin bacteria that causes infection. Alright, now we have another patient. What you want to do is, now this case is a pretty high yield. It's kind of interesting. Okay, so 24-year-old woman had sex with multiple people, developed syphilis. Okay, you do the check for the RPR. Okay, RPR, you see 1 to 256. This is very high. Like, so you divide the thing to 256 times, and then you still detect it. This means it's pretty high titer for syphilis. So you start penicillin. Okay, you treated that. This was 6 months ago. Now the titer 1 to 8. It's a little bit less, so this is good, but there is still positive. So what would you do? What's the best next step, you know, for syphilis titer? Okay, you just repeat reactive plasma reagent in 6 months. Okay, RPR, you repeat it in 6 months. Because, so there are 3 possible reasons for persistently positive non-treponema testing. Number 1, inadequate treatment. If it failed to fall 4-fold within 6 to 12 months, if it doesn't fall 4-fold, that's what we would aim for. If there's reinfection, you have another time you have sex with somebody with syphilis. If there is serofast reaction, okay? Okay, so it could be treatment failure, reinfection, or serofast fast, okay? So how do you manage each? If there is a treatment failure, okay, you like a persistent symptom, or it doesn't fall more than 4-fold, then in this case you do lumbar puncture to evaluate a neurosyphilis, okay, or do retreatment, of course. If there's reinfection, you just do retreatment. Okay, if there's new sexual partner, new symptoms, primary or secondary syphilis, a new treatment. Okay, if there is serofast state like asymptomatic titer fall by more than 4-fold, then you repeat VDR testing and check HIV status, and no treatment at this time. You just like if it falls more than 4-fold, just like keep an eye on them. Alright, other cases that you would want to think about. This one already summarized. So this one, if you see somebody with cough, lytic bone lesion, and they ask you what fungal, this is blastomycosis. If there is somebody dilation of bronchioles on CT, this is bronchiectasis. These are the only things that can cause that. And that brings us to the discussion of blastomycosis. What is the different? There are different types. There are for fungal infection. There are 3 common ones that you need to know: blastomycosis, histoplasma, coccidomycosis. Okay. Coccidomycosis is all the way to California, Arizona, and causes skin lesion, lymph node involvement, meningitis, osteoarticular infection. So it's kind of in the brain, causes some stuff. Histoplasma, it's in Mississippi, Ohio River Valley, Central and South America. Okay, so it causes hilar, mediastinal lymphadenopathy, hepatosplenomegaly, and causes pancytopenia and adrenal insufficiency. And the blasto, like in this case, causes bone lesion. This is the only one that causes bone lytic lesion. Genitourinary symptoms, it could cause cutaneous plaques, ulceration as well. Okay. Okay, so this is for blastomycosis. Blast bones and balls on the skin. Okay, so it causes a skin lesion and lytic bone lesion. Okay. Now, how about bronchiectasis? We talked about in the pulmonary section as well. There is a dilation. You want to treat the underlying cause, test for immunoglobulin, replace if needed, and you have recurrent infections as well. Okay. Now you have another case. You see 62-year-old woman came in with a blood culture positive for candida. Okay, this is big stuff, right? Positive candida. So the blood culture positive for candida, that's a kind of risky situation. So that what you want to do, you want to best next step, you want to check, you want to do eye exam. Okay, ophthalmologic exam. because all the patients need because there's could be endogenous endophthalmitis, so you want to rule that out. This is pretty risky, could cause blindness. Okay. Now you have this patient, 77-year-old woman, came in with fever, cough, myalgia, okay, that's like flu symptoms, and they ask what's the best next step. You give oseltamivir, okay, which we know that, you know, Tamiflu for the, and then that brings us, because they want to discuss what patient you need to treat influenza in, like patient of age less than 2 or more than 65 years old, if there's chronic pulmonary, renal, cardiovascular, neurocognitive disease, if there's nursing home residents, if someone is diabetic or immunocompromised or pregnant, if someone is age less than 19 on long-term aspirin therapy, if there's morbid obesity, if American Indian or Native American have flu influenza, treat them, you know. I don't know, maybe they're weak immune, I don't know. There are evaluation and management of pharyngitis as well, you've got to know. To manage pharyngitis, you have a few things that you need to look for, okay? There is the Centaur criteria. If there is fever by history, if there is tender cervical lymphadenopathy and tonsillar exudate, and no cough, okay? These are 4. If you have 0 to 1, no testing for strep infection. If there is 2 to 3, you do rapid strep antigen test, okay? And then you give penicillin or amoxicillin if it's positive, okay? If there is 4 of them is positive, you either can treat with penicillin or amoxicillin, or you can do rapid strep. If it's positive, then you treat. So the clue for that, you want to, if the patient doesn't have lymphadenopathy, no exudate, no fever in the history, then this may be less likely to be pharyngitis, right? So this is like just a way to limit antibiotics use and stuff. All right. Alright, so let's review what we discussed. We discussed oseltamivir for somebody with weak immune system, have influenza. Eye exam for blast, candida blast culture. Blastomycosis, blast your bone, pancreatitis dilation. Repeat RPR if it doesn't fall. Skin, when to give antiretroviral therapy. We talked about background for skin infection. Staph species like Titus, along with Pseudomonas. Perinephric abscess if no response to antibiotic. HIV, how do you diagnose it? Okay, and that concludes our discussion for the first section of infectious disease. We're going to continue to rock and roll and summarize more questions.